going from incidental findings all the way to critical systemic complications. We've got benign liver tumors, malignant liver tumors, hepatic infections and cysts, and finally, portal hypertension.
Kicking things off with Section 1, benign liver tumors. Observe or operate? That's really the recurring surgical question we always have to ask ourselves here.
So, cavernous hemangiomas. They're the most common benign liver tumor, and usually they're completely asymptomatic. You can safely just observe them. But watch out, because here's a classic high-yield trap. They can rarely trigger Kasabach-Merritt syndrome. This is a severe consumptive coagulopathy where platelets and clotting factors basically get trapped inside a giant hemangioma, and that demands urgent resection. Oh, and a crucial rule of thumb, never ever biopsy these, because the risk of massive severe hemorrhage is just way too high. Now this brings us to a classic surgical dilemma, telling focal nodular hyperplasia, or FNH, apart from a hepatic adenoma. FNH is basically a hyperplastic response with a classic central scar you'll spot on imaging. It almost never ruptures, so we just observe it. Hepatic adenomas, on the other hand, completely different beast. They're driven by estrogen and oral contraceptives, and they carry a massive 25 to 35% risk of spontaneous hemorrhage. The golden rule here is if an adenoma is over 5 centimeters or if it ruptures, you resect it.
So, when exactly does a liver mass escalate from a benign observation to a life-threatening malignancy? That critical when-to-cut question leads us perfectly into our next major category where the stakes get significantly higher.
Moving on to Section 2, malignant liver tumors. In this territory, early diagnosis and precise surgical criteria literally mean the difference between life and death.
Hepatocellular carcinoma, or HCC, is our primary concern here. It usually pops up in cirrhotic livers from Hep C, alcohol abuse, or other chronic liver diseases. The absolute must-know biomarker for your exams is an alpha-fetoprotein level greater than 200 nanograms per milliliter. Hit that number, and it's highly suggestive of HCC. You'll also want to look for imaging that shows arterial enhancement paired with delayed venous washout.
When it comes to surgical treatment, everything completely hinges on the state of the patient's underlying liver. If cirrhosis is in the picture, orthotopic liver transplant is your gold standard. You're taking out both the tumor and the diseased liver, assuming the patient meets the strict Milan criteria, of course. Now, if they have a healthy background liver, we prefer surgical resection, but, and this is a big but, only if it leaves a sufficient future liver remnant. We need at least 25% left over for healthy livers and 40% for diseased ones. And if they aren't a candidate for either, we pivot to local therapies like radiofrequency ablation or transarterial chemoembolization, better known as TACE.
We absolutely can't forget about metastatic disease. It's actually the most common liver malignancy in the US, mostly spreading from the GI tract. Operative resection of colorectal liver metastases gives us a really fantastic 25 to 45% 5-year survival rate. However, survival drops off a cliff if any specific poor prognostic factors are in play. We're talking about things like a node-positive primary tumor, multiple liver metastases, a disease-free interval of less than 12 months, a CEA level over 200, or a metastases larger than 5 centimeters.
But what happens when the liver's architecture is compromised not by aberrant cells, but by external invaders or structural defects? Because cancer isn't the only threat to liver parenchyma. Infections and cysts throw unique structural and surgical challenges at us, requiring a completely different management algorithm.
That brings us to Section 3, hepatic infections and cysts. Let's dig into these localized structural issues, where a really solid patient history, especially their travel history, can instantly dictate your entire treatment plan.
Your management path drastically diverges based on the pathogen. A pyogenic abscess is bacterial, often stemming from intra-abdominal sepsis like a ruptured appendix. That's going to require percutaneous drainage and IV antibiotics. Conversely, an amoebic abscess, caused by the parasite Entamoeba histolytica, is usually linked to travel in endemic areas. The huge takeaway here? Treat amoebic abscesses almost exclusively with systemic metronidazole. Surgery or drainage is pretty much obsolete for these unless medical therapy completely fails.
And for parasitic echinococcus cyst or Hydatid cysts, there is one absolute non-negotiable surgical rule: do not aspirate initially. Literally, sticking a needle in these cysts can cause parasitic spillage, which can lead to sudden fatal anaphylaxis or peritoneal seeding, basically spreading the disease throughout the entire abdominal compartment. Definitive treatment requires scalacidal agents and a formal operative parasystectomy. So, how do we manage the domino effect when liver disease alters systemic hemodynamics? Let's take a step back and look at the whole systemic picture. What exactly happens when a diseased, cirrhotic liver becomes so fibrotic that it actively obstructs its own blood supply? Welcome to Section 4, Portal Hypertension. This is the ultimate systemic complication of liver cirrhosis, bringing with it ascites, portosystemic shunting, and life-threatening varices. When normal portal flow is disrupted, it causes some severe back pressure. We measure this using the hepatic venous pressure gradient, or HVPG. The magic number you've got to remember for your exams is 12 millimeters of mercury. Esophageal varices simply will not develop until the HVPG hits that 10 to 12 mark. Therefore, medically bringing that pressure back down below 12 with non-selective beta blockers like propranolol is our primary therapeutic target for prophylaxis.
But what if a varix actually ruptures? Well, here's your life-saving procedural flow for acute variceal bleeding. Step 1. Immediate ICU admission and endotracheal intubation. You have to do this, or these patients will massively aspirate blood if you don't protect that airway. Step 2. Fire up an octreotide infusion to clamp down on splanchnic blood flow. And Step 3. Emergent upper endoscopy for definitive endoscopic band ligation.
When endoscopy fails to control the bleeding, we have to escalate to TIPS, transjugular intrahepatic portosystemic shunting. We're literally placing a stent right through the liver to connect the portal and systemic circulations, which provides immediate decompression. But there's a massive clinical trade-off here. By bypassing the liver, you're shunting unfiltered ammonia-rich blood directly to the brain. You're effectively trading deadly portal pressure for a significantly higher risk of hepatic encephalopathy.
We've covered some incredible ground in this explainer today, from the watchful waiting of hemangiomas to the emergent stenting of portal hypertension. As downstaging therapies and transplantation criteria rapidly evolve, it leaves us with one fascinating question to think about. How will we redefine the very limits of resectability to save even more lives in the coming decade? Thanks for joining me, and keep studying smart.